Hello, my name is Lauren Gracy. I'm an advanced epidemiologist with the Kansas Department of Health and Environment, and I'm going to talk to you a little bit today about zero suicide in Kansas. First, I'm going to start with a brief video that we put together at KDHE.
Every minute of every day, suicide affects the lives of Kansans. It takes individuals away from loved ones, and communities lose their most valuable resource, their people. About 10 people in Kansas die of suicide each week, and most saw a healthcare professional in the year prior to their death. Zero suicide is a call to action based on the belief that suicide is preventable, using a systematic approach to create a new culture around suicide prevention. 3 specific evidence-based interventions are central to zero suicide. First, we must make it okay to talk about suicide. Healthcare must routinely screen for suicide risk by starting a conversation, creating a connection, and acknowledging anguish and pain. Second, the strongest resource in preventing suicide is a person at risk. Collaboratively designed safety crisis plans should include reducing access to lethal means and following up with phone calls after discharge. Third, we must treat suicide directly. Treating mental health or addiction does not always remedy the pain that underlie thoughts of suicide. Zero Suicide trains health professionals to deliver specific treatment as well as caring and supportive contact, either between appointments or post-care follow-up in the weeks and months to come. We are proud to be the lead organization helping healthcare professionals take steps towards zero suicide in Kansas. With insightful leadership and commitment, we'll make significant strides toward ending these tragedies. Zero suicide. Healthcare that values every life, every day, every time.
The Zero Suicide Grant is a 5-year grant that comes from the Substance Abuse and Mental Health Services Administration, or SAMHSA. We first got this funding in August of 2020, so we just entered year 4 of our 5 years. This amount of funding for suicide prevention is the first of its kind at KDHE. And SAMHSA has a target age group with this funding for adults aged 25 years and older, but we do believe that the Zero Suicide Framework works across the lifespan. And then activities here at KDHE revolve around helping organizations with implementation and funding that implementation to implement safer suicide care. We know that there are specific protocols in place at hospitals when someone presents to the emergency department for a heart attack. There's a care pathway in place for what the staff needs to do and resources provided to the patients. And the zero suicide model hopes to create a similar type of care pathway when individuals are in care specifically for suicidality. So they are presenting to the emergency department with suicidal ideation or to a behavioral health care setting with suicidality. So zero suicide is a way to improve suicide care within health and behavioral health systems. The mission of zero suicide is really like a quality improvement model to transform system-wide suicide prevention and care to save lives. And I really want to highlight this last bullet point, the commitment to a restorative just culture, because no one is to be blamed when someone in their care dies by suicide. It was a system failure, not an individual person's failure. So we can just learn to do better and fill that gap. The charge for zero suicide is led by the state team here at KDHE and partners at the Kansas headquarters, Kansas. My apologies, they just changed their name and I'm trying to get used to it again. So they can provide consultation and technical assistance for any or all of these elements as they're needed by organizations. The lead element, so when we're thinking about systems change, it's important for leadership to be supportive and involved with this project. We've seen how important it is for leadership from multiple departments to be involved in implementation, maintenance, and quality improvement efforts. Under the train element, this kind of states that for every level of interaction with a potentially suicidal individual within an organization, there should be identified trainings to provide the workforce with the knowledge to support those suicidal individuals. At a minimum, everyone within an organization should have an understanding of suicide prevention and the belief that it's everybody's business. So think of like a gatekeeper training. A common one is question, persuade, refer, or mental health first aid. And yes, even your administration and IT and accounting should have these base level understandings of suicide prevention. And as the level of interaction with clients increases, so should the level of suicide prevention training, to where someone like a clinician who is treating individuals receives the most amount of trainings. And these trainings support best practices for suicide prevention, including screenings, assessments, management and treatment, and then evaluation of individuals throughout their care. For the identify element, we need to know who is suicidal through the use of ideally universal screening. So anytime someone is in your care, every single individual that comes into contact with your organization is being screened. We support the use of the Columbia Suicide Severity Rating Scale, or the CSSRS, as it's considered the gold standard. But we also recognize that agencies have different needs, and there are other tools such as the PHQ-9 or the ASQ, which can be used for screenings. For the engage element, once someone has been identified as being at risk, they should be involved in their care pathway, essentially. We promote the use of collaborative safety planning. So we're asking the individuals, what are their triggers and what can distract them, or who are their support persons, and how to really combat their plan if they have one, such as having a discussion around removing lethal means from the home with that individual's input. The safety plan and mean restriction is not meant to be prescribed to individuals. This isn't, here's what I think you should do to be safe, but rather, what do you need? What can you do? What can we help you with to keep you safe? Some individuals will need intense treatments. So that's where the treat element comes in to target suicide specifically. There are several recognized evidence-based treatment modalities supported by the Zero Suicide Framework, and those are dialectical behavioral therapy, or DBT, cognitive behavioral therapy for suicide prevention, or CBT-SP, and then the collaborative assessment and management of suicidality, or CAMS. Discharge from emergency departments or inpatient behavioral health care is often one of the biggest gaps in our system of care, which is why the transition element with warm handoffs and in contacts is so important to close gaps. Caring contacts are inexpensive and an effective suicide prevention practice. They could look like postcards, telephone calls, emails, where for people who are transitioning between mental health care providers or behavioral health care setting to community behavioral health. And then the final model is improve. As I said, the Zero Suicide Framework really is kind of a quality improvement model. So agencies should use the data that they have within their organization or from partners that they can get, and they can build it into their electronic health record too, to track patient outcomes, to identify the gaps in their care and help inform creation of their processes and protocols and policies specific to suicide care. So why is zero suicide important to public health? And that's because suicide is a leading cause of death among Kansans. So suicide in the green box, the second leading cause of death for those aged 10 to 44 between 2016 and 2020, and then 8 still for those 55 to 64, and 4th for 45 to 64. And it's not pictured, but the year 2020 alone, despite COVID, suicide was still the 9th leading cause of death for all ages in Kansas. In 2021, there were 555 suicide deaths in Kansas with a rate of 22.5 per 100,000 Kansans. And there was a statistically significant increase, almost 45%, between 2011 and 2021. We've seen a statistically significant increase in suicidal ideation emergency department visits between 2016 and 2021. And for every single Kansan that died by suicide in 2021, there were 6 that had visited the emergency department for a suicide attempt or intentional self-harm, and then 15 who visited for suicidal ideation. Between 2011 and 2021, males made up about 80% of suicide deaths. They have a rate that's about 4 times that of females. However, females are more likely to attempt suicide than males. 57% of emergency department visits for suicide attempt were females, and 65% of visits for intentional self-harm were also females. Firearms are the most commonly used method of suicide in Kansas, really nationwide, but also in Kansas. And there was a statistically significant 55% increase in firearm suicide rate in about 11 years. I'm going to briefly touch on some circumstances that come from the violent death reporting system at KDHE. So nearly half of people who died by suicide had a current depressed mood or a mental health problem around the time of their death. 32% of suicide decedents reported or had reported having an intimate partner problem around the time of their death. 25% of those who died by suicide were reported to have a physical health problem. 39% had a history of suicidal thoughts, and then about 30% had recently disclosed their suicidal intent to someone or had left a suicide note. And then this statistic really drives home the need for zero suicide in public health, healthcare settings. And that's about half, 45% of people who died by suicide had contact with their doctor within a month prior to that death. And then we see that percentage increase somewhere between 80 and 95%. The literature is a little different. For the year prior, they had seen their healthcare provider. So what are we doing right now in Kansas? We have an advisory council made up of a variety of partners that guide the work that we do. So those look like involvement with the local and state suicide prevention coalitions, our headquarters Kansas partners, the Kansas State Department of Education, and KDADS, and I won't read all of them, but we have a wide variety of partners that do suicide prevention work to help guide this work. We provide funding for training, so they are completely free. Those come from primarily the headquarters Kansas folks. We have live trainings that are going to be on the books very soon, as well as on-demand trainings from their website. We also provide a Zero Suicide Academy and workshops, usually about once a year for each of those. And then we also contract with the Kansas Healthcare Collaborative on a pilot project to expand the zero suicide framework into a couple of primary care clinics, where the Kansas Healthcare Collaborative is helping them set up a very brief, short care pathway, essentially. And then using our grant funds, we contract with community mental health centers and health systems, community health clinics, other behavioral healthcare organizations, even substance use treatment organizations, because we see such a tight overlap between substance use and suicidality. And we're also starting to get into local health departments. So here at KDHE, we've worked hard to develop shareable written materials, such as a fact sheet and brochure, infographics for tabling events. Several times per year, we present the zero suicide model, such as now at state conferences, or have exhibit tables to spread the word. And as the state suicide prevention epidemiologist, I've presented at national conferences for injury prevention and epidemiology. Additionally, we host, like I said, zero suicide workshops and academies with the Zero Suicide Institute or Headquarters Kansas to get people involved and spread more detailed information about the model. Much of our work has also been shared out via our network of state agencies and coalitions, and then also the health and behavioral health care organizations, such as those that sit on our advisory council. In 2021, we developed a webpage to house the documents we created and information on the framework. And in 2022, we published a dashboard that has data on trends and demographics, geographical regions for suicide and suicide-related morbidity, such as self-harm, suicidal ideation, and attempts, and a page on zero suicide indicators. And I think I'm going to pull that up now too, so that I can show you as I am discussing it. So this is our main page, landing page. You can just Google zero suicide KDHE or come to our website and Google and do the search bar for zero suicide or suicide, and you should be able to pull it up. So we have contact information. We have my section director now, our project manager. Once they are onboarded, we'll have their contact information here, as well as me. If you have questions about data or about the zero suicide model, you can reach out to me as well. Then we have, some introduction about the zero suicide in healthcare. Then our video that I showed you at the very beginning, and then all of our resources are towards the bottom of the page with a lot of these documents that I was just discussing with our brochure and fact sheet. There are a couple of data reports that exist under the data tab with lots of data over the last couple of years, and then you can link directly to the Zero Suicide Toolkit from the Zero Suicide Institute and Suicide Prevention Resource Center. And then if you scroll even further down, we have some brief definitions of each of the 7 elements. And then I will also show you around the dashboard quickly to orient you, so it's not so much of an abstract idea when I'm discussing it. So we have, how to use the dashboard, and then you can click around. We have a bunch of different tabs, and you can choose if you want to see the graphics as counts or rates, and then you can hover over pretty much any data point that exists to get more information. Or if you don't want to flip back and forth, but you want to see the count, you can hover, and that'll give you the year, the count, the rate, and if you're interested, the 95% confidence interval. So we have age group trends, mechanisms, geographical regions with a map where you can select county, or if you have partners with community mental health centers, they might be interested in seeing data and how it compares between the catchment areas. And then we also do a lot of work with our trauma program here at KDHE, so we've included the trauma regions as well. And then we have very similar pages when it comes to the morbidity data, and just like you can filter with counts and rates, we have the option to kind of filter between emergency department visits, hospitalizations, and you can filter by diagnosis. We can see all of them if you're interested. And then they are laid out very similarly in that we have the breakdown by sex, by race, ethnicity, the age group pages, and then you can see the trend lines for age groups as well. The syndromic data is also emergency department data, but this is more real time. We have at this point up to August 2023 available, and you can use these maps to filter all of the graphs down below. And then we have the age and sex pyramid with also race, ethnicity. The last tab with any kind of data are these zero suicide indicators. So this shows us kind of a lot of the numbers that I will also get into on the next couple of slides about things that we've been able to collect data that we get from our funded and even some unfunded organizations to show off what we're doing in Kansas with zero suicide. And then finally, the last page are some technical notes with definitions that that you might need to know throughout this, and information on, you know, calculations. So now I'm going to get into some of the data that we were collecting from our organizations. So in year 3, the year that we just closed out, we had 6 fully funded organizations. There were 5 in year 2, so 4 agencies continued with us for year 3, and then we gained 2 new agencies. A few of the accomplishments for our partners, all sites have implementation teams that meet regularly. It's a really important step with zero suicide, is having an internal group to guide that work. So you see the range kind of varies by organization. We have some smaller organizations that only have maybe 5 or 6 people on their implementation team, and as many as 14 members for those larger organizations that need a lot of input. But we've really noticed that having at least one person really be a champion for zero suicide can make a lot happen in an organization of any size. Another tenet of suicide prevention work in the zero suicide framework in general is to incorporate voices from persons with lived experience. So we've seen an increase in the number of our implementation teams that were able to include people with lived experience. So we had only 3 in year 2 reported that, and then up to 5 in year 3 reported they had at least one person with lived experience on their team. And then all agencies are reporting leadership support, of course. The numbers on this slide are an aggregate count of trainings from year 1 through year 3. All of these trainings were provided by vendors, mostly from Kansas, headquarters Kansas, or the Zero Suicide Institute, and also CAMS Care. And then also our implementing agencies might have a trainer on staff to provide these as well. So this is an aggregate of all of those for these evidence-based suicide prevention practices. So this number has probably increased since the last time I pulled this. We might be pushing closer to 4,000 now. We provide a lot of trainings for those gatekeeper, as I said, QPR and mental health first aid. We have a lot that will do the lethal means reduction, the counseling on access to lethal means training, and the screening trainings as well have been very popular. Through zero suicide, just in year 3 alone, over 35,000 individuals were screened for suicidality. And this data was only up to Q3 of the grant year. So this has probably increased as well once I get those numbers in. And all of our agencies have already incorporated their screening tools into their electronic health records, so that when someone is screened as high risk, it will flag in their EHR so they know to be assessed or put on a pathway as needed. For Engage, we've had 46 individuals enrolled so far in the Zero Suicide Framework. So when we say someone is enrolled, that means that they are placed on a pathway of care, and we can collect a certain amount of data on those individuals through our funded organizations. We have distributed over 2,000 gun locks, over 900 lock boxes, nearly 1,700 drug deactivation or deterra bags. And then organizations may also pass out flyers or have posters in their lobbies to kind of show medication take-back events, or maybe drop boxes, where to find lock boxes, other stuff for that kind of lethal means restriction. In years 2 and 3 of our grant, over 2,000 individuals were referred for treatment of suicidality, and all agencies reported using evidence-based treatments. Not everybody that ends up being referred for treatment is going to end up being in treatment, essentially. There might be some brief intervention that is done on that individual, provided a crisis contact, or gone maybe try to get in contact with a mental health provider. Currently, most organizations in place refer to their local community mental health center for suicide assessment and treatment. So that transition element really is vital with warm handoffs and caring contacts. So in year 3, our funded agencies grew their were able to grow their transition element as well as their improve element. So this time last year, only one agency had a policy in place to assess their organization's fidelity to the model, and currently there are 4 agencies with this policy. And then quarterly, I receive data completed by the implementing organizations to show you all of this data that we have today. Some are also not funded. We get some data from organizations who have gone through an academy and decided to implement and have been kind enough to provide data to us. And then, so 15 total agencies submitted data, and nearly half of those were not funded. That is it for me. We'll share my references, and I will leave my contact information up for a brief moment if anyone wants to take a screen grab or write it down. Again, I'm Lauren Gracy. Thank you so much for having me present at the symposium. If anyone has any questions at all, needs any data ever around suicide or mental health, please feel free to reach me at lauren.gracy@ks.gov. Thank you so much.